Welcome everybody to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for February 3rd, 2022. Today's CMA activity code is 484713. We have a good case today. It's my case. It's relatively straightforward, but I think it should stimulate some discussion. We welcome everybody that's here today. I want to welcome a good friend of mine, Dr. Swapnil Hiremath from Canada. It's the first time I think he's joined us, and it's great to see him. I promised I wouldn't count on him, call on him though, and his name's not on the wheel. So, but good to see you, Swap. Welcome. Hope you can make it again. We've got at least two Canadians, right? But probably more that I don't know. But Dr. Reen is a regular follower here. As usual, this case has been de-identified, and we have nothing to disclose. These are being recorded. It will be up on our YouTube channel shortly. We do have a privacy statement I want to read to ensure patient privacy is preserved. We are identifying all information. Gender has been changed to disguise the identity of the patient. We are being even more careful than usual on this. So this is very important in this day and age. So I wanted to point out our new privacy statement. And here's the protocol. This patient is a 21-year-old Asian female who was referred for microscopic hematuria and non-nephrotic range proteinuria in the setting of a normal serum creatinine. She was initially seen by her primary care physician 2 months prior to presentation after she developed a cough, a sore throat, rhinorrhea, and tea-colored urine 1 to 2 days after the onset of her upper respiratory tract symptoms. She tested negative for COVID. Routine labs at that office showed a urinalysis with 1+ protein, 2+ blood, 5 to 10 RBCs per high power field. Her serum creatinine was 0.6 and her serum albumin was 3.8. She was empirically treated with amoxicillin and resolution of her symptoms and clearing of her urine. Other pertinent laboratory findings included a normal CBC, LFTs, but she did have a positive ANA of 1 to 320 with a centromeric pattern and subsequently seen by a rheumatologist. She saw this person, further testing was done and showed again an elevated ANA with a centromeric pattern and an anti-centromere antibody mildly elevated at 3.2. Her SED rate was 35. Her urinalysis had 2+ protein, 3+ blood, 8 RBCs per high power field, and her urine protein to creatinine ratio is 1.2 grams per gram. Her serum creatinine was now 0.8 milligrams per deciliter. She had a normal serum C3, C4, her CBC, LFTs, antiphospholipid antibodies, SSA, SSB, anti-double-stranded DNA, anti-Smith, and ASO titers. Everything there was all normal or negative. When we saw her, her urine had cleared. It was no longer pink or red, but she noticed some bubbles. She had an itchy rash over her stomach and bilateral lower extremities for the past 2 to 3 weeks, which were preceded by a transient stomach ache after she ate outside. Her family member had some vomiting also after eating the same food. She not had any rash over the buttocks or other parts of her body, but has noticed a mild malar pattern rash for the past 2-3 months. Her weight had been stable, although she had unintentional weight loss of about 15 pounds before starting school. She not had any fever, arthralgias, difficulty in swallowing, discoloration of fingers, or a sore throat. Her past medical history was unremarkable. Her past surgical history, she had none. There was no family history of renal disease. She was on no meds and had no allergies. Her review system was only remarkable for her change in urine color and the rash, but she sent me pictures of them. Although they were poor quality, I really didn't see much there. On physical exam, her she was 5 feet tall and 98 pounds. Her blood pressure was 114/70. Her heart rate was 64. She was very healthy appearing, no rash, lungs were clear, heart was normal, abdomen was normal, joints were normal, throat was normal, tonsils were not enlarged, and she had no edema. On laboratory exam, her sodium was 138, her potassium was 4.3, chloride 104, bicarb 24, her BON was 13, and her creatinine was 0.8 milligrams per deciliter. Her blood glucose was normal at 80, her albumin was normal at 4, calcium was normal at 10, her bilirubin and liver enzymes were all normal. Her ANA, as I mentioned, was positive. Her double-strand DNA, however, was negative. C3 134, C4 20, SED rate was 135, ANCA was not done, and ASO was not done. Hepatitis C antibody was not detected. Hepatitis B surface antigen was negative. On CBC, her white count was 7,000, her hemoglobin was 13, MCV was 83 with an RDW of 13, and her platelet count was normal at 290,000. Her urinalysis had a specific gravity of 1.008, a pH of 5.5, a dipstick 3+ protein, 3+ blood, 0 white cells, 8 red cells, and a protein creatinine ratio of 1.2 grams per gram. She was scheduled for renal biopsy the next week. She received her COVID booster in between our visit and the scheduled renal biopsy, and she noted her urine to turn pink the day after her COVID booster. She had no other symptoms from the shot. On ultrasound, and the biopsy was about 2 days after that. I think we saw her on a Tuesday. Her booster was on a Friday, and we biopsied her on Monday. On ultrasound, her kidneys were 10.6 and 11.4 centimeters in length, and a percutaneous renal biopsy was performed. Anybody have any questions about the protocol? That's because it's such a perfect protocol. What can I say? I think we have a poll that I wanted before we have anybody discuss it. Pravir, can you put our poll up? Okay, so we have a short poll, and we have 4 options for the poll. This patient has IgA nephropathy 100%, IgA nephropathy 90%, thin basement membrane disease 10%, IgA nephropathy 80%, thin basement membrane disease 10%, lupus nephritis 10%, or something else. So take your time. No one gets identified by their vote.
Couple more people. A few more votes. There we go. All right, that's pretty good.
Yeah, we got 34 people voting. I could 35. Okay, poll ended. We got 35 people. 40% said IgA nephropathy, 100%. 10% said IgA nephropathy, 90%. Thin basement membrane, 10%. You had to make up some numbers. 40% said IgA, 80%. Thin basement membrane, 10%. Lupus nephritis, 10%. And about 10% said something else. So, that's why we do biopsies, of course. Although, we could actually talk about what level of proteinuria and hematuria do you not biopsy? I think she probably qualifies pretty easily, but I've seen people write situations where they wouldn't biopsy some people with milder presentation than this, with everything else being normal, and I've always had a problem with that. But I think that she's high enough. I don't think many people would argue with doing a renal biopsy. I want to ask Dr. Whittier to start a differential diagnosis. Bill's the type of person that I guarantee you he was an IgA nephropathy 100%, because whenever we ask Bill his diagnosis, he always gives us the first 5, and they're always the same. So, Bill, what did you vote?
Something else, 100%.
There you go. Always throw me for a loop, Bill. I like that.
So no, I think you have as Swap said on the chat, I think you have a young Asian woman with microscopic hematuria, non-nephrotic proteinuria. A lot of times we just go by the first sentence. That's certainly how I look at my CPCs for the New England Journal articles. And it really does scream out IgA nephropathy is number one. There are a couple little things that are more consistent with IgA here. She also had a sore throat right after the same time. The synpharyngitis goes along with it. Her negative serologic workup, exceptionally mild positive ANA, that doesn't really sway me so much more towards lupus, although of course people can have latent lupus in their first presentation, could be lupus nephritis before they're serologically so much more positive. The rash is also pretty interesting. We could think about, we think about rash with IgA, we think about HSP, and that's usually not on the abdomen. They get abdominal pain, but they don't get an abdominal rash as much, as it's more peripheral. So that doesn't really quite fit either. And she didn't really have a history of abdominal pain, except for all the diarrhea that she had, or the diarrhea in the recent eating after the same food. So I think it is IgA number one, but if I wanted to expand it, if you do have a infectious diarrhea and it could hit the whole family, you would think about an HUS type situation with Shiga toxin, but she doesn't have anything that really looks like a TMA. And with the fact that you said the rash wasn't much there, especially on a picture, she could always have something as rare as Febre's. I mean, she could have angiokeratomas on her abdomen. That's a common place for those to be. They're often flared by the belt buckle or areas of constriction against the skin. And so that's something that I would think about. She's a woman, obviously. We don't think about it as we always think about the most common as X-linked, but there's autosomal recessive, and Fabry's definitely exist in females. So even though I think it is IgA, I think just to complete the differential, I would include thin basement membrane / Alports. I would include lupus. I would include Fabry's, all there in the differential. But I'm probably 90% on IgA, maybe 95.
So what did you vote?
IgA. I put IgA. Sorry, I didn't put anything down, but I was thinking that it was IgA.
Oh, that's right. Yeah.
Sorry, the host can't vote, and so
Yeah.
that's why but I was thinking it was going to be IgA 90% is what I was thinking, and maybe it was, what was it, 10% thin basement membrane, or something like that.
Yes, and the third was 10% basement membrane or lupus. So what you think this is possible? She could have lupus?
Yeah, I mean, I think it's pretty unlikely. I kind of said that it could be. Obviously, it's a young woman, and we've got a positive ANA and hematuria.
And she's Asian.
And she's Asian. It absolutely could be, but I'm just not that impressed by the serology right now. And I don't know. It just seems a lot more like, but lupus is in the differential. But I think it's a lot more likely that it's IgA.
Casey, she got her vaccine in between the biopsy. She said, I'm scheduled to get vaccinated. Should I put it off? And I said, you know what? We don't want to lose the schedule that you have. Go ahead and get it. And then her urine turned a little bit red. Does that mean much to you?
So this happened the day after she got the vaccine. I feel like if we were referring to sort of a flare of a disease as a result of vaccine, that has to be immune mediated. And it's not really likely that in 24 hours, she produced that much IgA or IgG that this would contribute to this. So I think this probably is just an epiphenomenon and not really a cause and effect. And she had this before. She had T-color urine before she got the vaccine. So to me, I feel like the timeline of how quickly it happened makes it less likely that's vaccine related. But anywhere from a few days until a few weeks to months after, up to 3 months, you can kind of maybe blame the vaccine, but this is just too quick.
Last week we talked about minimal change coming on shortly after the vaccine, and I think Mario said it was within 2 weeks, Dr. Rubin. And the number one inflammatory GN that seems to be exacerbated by vaccination is IgA. What I should have looked up and didn't even think about is what is the timing of that? I mean, for the discussion, what is the timing of that? Is it immediate? Because when you think about IgA nephropathy and somebody gets a sore throat, they will get gross hematuria often the next day, as she did originally. So, your comment about taking time for an immune response, it may not take time for immune response. It may just make time for release of some antibodies or something that are pre-made. So I don't know that really matters. But what I don't know is in the literature, the people that got their IgA flare after vaccine, what the timing was. I don't know if anybody knows. Mario, do you know?
No, the only thing I recall is the 2 weeks limit.
Yeah. Dr. Reen brought up the case. He said, I think there are a recent report of lupus after vaccine. Yeah, that just actually came out. I think it was a pre-publication release. It might have been from KIO Reports or something with now lupus. So that's kind of interesting too. Although I don't know that, I can buy IgA. I don't know that I can buy lupus would be that quick. But again, I don't know the timing of that. Or maybe she's got lupus and maybe the vaccine made it worse. So, I think these are all interesting. I didn't take it as a coincidence that, she got vaccinated and then got a little worse, but it could have happened either way. Who has any other thoughts about this? Dick, what are your thoughts?
Well, I would agree with most everything that everybody has discussed. I would point out that there is an ancient history of IgA nephropathy showing manifestations of other autoantibodies. And a very nice survey done in Australia way back in the 80s showed an increased prevalence of ANA and other autoantibodies in patients with IgA nephropathy. So I would find the serology here very difficult to interpret, at least in light of increasing the likelihood of lupus nephritis.
Is this thought to be just a generalized autoimmunity predilection?
Well, I think patients with IgA nephropathy often have other features of autoantibody production. Perhaps that is what this patient is expressing rather than a manifestation of a different disease.
And Bill, if this were a lupus lesion, what would you predict it to be?
You know, it's always hard to tell, but I'd probably say it seems so mild. She has normal blood pressure. There's some hematuria, 1.2 grams of proteinuria. I'd probably pick a mesangial lesion, which is also why I'm kind of thinking about IgA nephropathy. It's another different mesangial lesion. So I would go with mesangial lupus if it were my number one. But you know what's kind of funny is I was reading it again, and you know, if this question's on your medicine boards, you're usually nearing your differential down or to answer the question between a post-infectious glomerulonephritis from strep and IgA. And they're always wanting the internist to make sure to know that the post-infectious one is hypocomplementemic and the sore throat is quite a bit before the pharyngitis. And that's what gives you the hint, like in this case, that it would be more IgA. But it's funny that no one even said post-infectious because it was almost so classic for IgA.
I think it's, or it would be highly unusual for post-infectious, but I think that's a really good point. That it's kind of funny, nobody even brought it up. She has, you know, sore throat and she has gross hematuria. I don't know the answer to this, but maybe somebody does. But I maybe have seen it once where someone with lupus has had gross hematuria with their glomerulonephritis. Does anybody else have any experience or know any data on that? I think it has to be pretty unusual. You know, they say that you can have gross hematuria without any GN, but in the end, it's, you know, it's often 2 or 3 things where you see it. Anybody have any thoughts on gross hematuria and lupus nephritis?
Lupus, I don't know. My top 3 are usually IgA, maybe MPGN, and post-infectious. I don't think about lupus as having one. I'm sure it could happen. Obviously, warfarin nephropathy could be too, but
Good point.
I don't know about it. I don't really know about it in lupus.
Dick, you have any thoughts on gross hematuria in lupus nephritis?
Pretty uncommon, I think, Roger, and a gross hematuria would lead me to suspect IgA nephropathy much more than lupus nephritis. We have to remember, as was pointed out by Bill, this is synpharyngitic hematuria. There's no latent period here, and the complement is normal. So, you know, post-infectious, at least from a post-streptococcal GN, seems quite unlikely here.
Great. I think let's get to the wheel and we'll see who's going to read the biopsy. Oh, great wheel. Tell us who reads. All right, Chintav, one of our first-year fellows.
All right, so this is the trichome strain. We got a good core here. I see several gloms in there. We're looking for fibrosis here, the bluish staining material. I see the tubules are really packed tightly together. I see some focal area of bluish staining material, but otherwise it looks pretty good. I would say it's like maybe like less than 15% fibrosis.
Yeah, I don't really see any fibrosis here. I see a little, yeah, right there. That's around a normal artery, so the connective tissue supporting an artery. Yeah, it looks like a good preserved core of renal tissue.
Okay, so we got a PA stain here. We have 2 gloms, one on the right, one on the left of the screen. We also have some tubules here, so I'm going to focus on the one on the left side first. So looks a pretty good glom here. There's some areas of mesangial hypercellularity that I see here. The one right here at around 2 o'clock. Maybe this little area here. The capillary loops look fairly open. but most of the places, the basement membrane looks good. So I would say like focal areas of mesangial hypercellularity.
How about the mesangium itself? Does it look normal or expanded?
It does look expanded.
Okay.
Yep.
Yeah, I agree.
All right, and then the other one on the right side of the screen also has some mesangial hypercellularity as well as expansion right here around 3-4 o'clock. Maybe this one right here, but otherwise the capillary loops, I don't see any endocapillary proliferation or hypercellularity here. So all in all, this and then the tubules obviously look for ATN on this stain. So I see the brush border intact on most of them. I don't see much ATN in this PAS stain.
Okay, I agree.
Oh, what happened here? All right, so this is the H&E stain. We're looking at one glom in the middle of the screen. Right off the bat, I see at maybe like 2 o'clock or 3 o'clock, there's like this area of mesangial, hypercellularity as well as mesangial expansion. There's also some right in the middle of the screen right here. Maybe a little area at 11 o'clock right here. Otherwise, the capillary loops look open to me, no endocapillary proliferation. I don't know if this is like sclerosis or maybe just like, I'm not sure, Dr. Symbolic, what this is right here.
Those are unlysed red cells.
Okay, unlysed red cells. Okay, so basically mesangial hypercellularity with mesangial expansion, but otherwise I don't see anything on this glom. It looks pretty preserved, no crescents or anything.
Yeah, good.
Really cool. You can actually see the biconcave discs there in the capillary on the
David,
red cells.
David.
Yeah.
Yeah, Mario, I have a question for you. It is said that you should not count the cells near the hilum to attest to the presence or absence of hyperplasia. Why is that?
Oh, because typically in the hilum, you do see hypercellularity. Generally, you want to look out at the periphery to determine if there's hypercellularity or not. Yeah.
All right, thanks.
I gotta say, that's a pretty cellular hilum.
Yeah.
Which is maybe Mario's point, but yeah, you really can't, but that's a pretty cellular hilum.
Yeah. I think this is beyond the normal for a hilum. Yeah.
Okay, so we have a jeweled stain here or silver stain. We're looking at one glom. We look for spikes or break. Here, I don't see any spikes. The basement, I don't see any breaks in the membrane. Fairly looks intact glom to me. I don't see any breaks or spikes in here.
What is prominent?
Oh, like the mesangium.
Yeah, I mean, this is really stresses how expanded the mesangium is there. Shintav, we had 3 things on our poll. We had IgA, lupus, and Bill said if it's lupus, it's mesangial lupus, and thin basement membrane. How do you feel? What's still in the running for you?
I mean, so looking at this, I mean, I would say the basement membrane looks fairly normal. So I would say but still lupus is in the question because you can still have like mesangium. So you're probably going to wait for the immunofluorescence for lupus. And IgA obviously is in the running because we're seeing so much mesangial deposits and, proliferation.
Yeah, and what you're seeing here is the whole loop, so you really can't comment on the thinness with this here. You really need to measure in the EM, but I would say that degree of mesangial expansion would be high, would not really fit with a thin basement membrane. Realizing that there's a lot of patients that have coexistent of IgA nephropathy and thin basement membrane, but so I think that it'd be unlikely to be thin basement membrane. But yeah, you're absolutely right. I think until we see the immunofluorescence and the pattern of the immunofluorescence, I think lupus is still in the picture.
Mm-hmm. Okay, so this is an H&E stain. We're just looking at, I think, the tubules here. I mean, no, this is like an unlysed RBC again, Dr. Symbolic, or cast.
Yes, yeah. These are red blood cell casts.
Yes, okay.
Yep.
And same, this one is also a red blood cell cast, right?
Yes,
Right.
yep.
Okay, all right. Let's see.
Yep, and that was the point of this picture, that there is glomerular hematuria.
Okay. Okay, so we have immunofluorescence here that's positive for IgA with predominantly mesangial deposits here. I don't see any deposits in the capillary loops or anything. So I got pretty strong IgA positivity with mesangial deposits are positive in the mesangium.
Yep.
Okay,
So Chintav, with that IgA up there, lupus is kind of still in the differential because it tends to be a full house. But David, sometimes they'll put up blank slides for IgG or other things. So the fact that it's limited to IgA does make that, diagnosis. So.
Yeah, right. So the IgG was completely negative, C1q negative. So that, and also the lambda was a little stronger than kappa, which is typically seen in IgA nephropathy. So I think this is, there are no hints of lupus nephritis, no features of that.
Okay. So we have a electron microscopy here. So we have, this is the blood space, this is the urinary space. Looking at the base, I don't see any endothelial deposits or subepithelial deposits. The food processes look normal to me. I see a lot of mesangial deposits right here, all this.
Yeah. So those are actually nuclei.
Oh, okay.
The amorphous material will be a deposit. Do you see any of that just below your arrow?
Oh, that's right.
Yeah,
here.
right there.
Okay.
There you go.
All right. Yep. All right.
Yeah, and then up at the very top of the screen around 12 o'clock, that amorphous stuff to the right of that. Oh,
right,
there you go.
Okay.
Well, that's the basement membrane paramesangium, but there's a deposit there.
So this is another EM blood space, urinary space. Again, the basement membrane, we were looking at, that was on our differential thin basement membrane disease. I think this looks like a normal basement membrane. I don't see anything. I mean, I'm sure you probably measured it as well. Don't see any deposits in the endothelium or epithelial, subepithelial or subendothelial deposits. Again, quite a few mesangial deposits. This is like what I'm pointing out. Is that all amorphous material, Dr. Symbolic, right here?
Yeah, the darker amorphous material are the deposits.
Okay.
We call it electron dense material.
Okay.
Yeah.
Right there.
Yes, there you go. Yeah.
Yeah, Chintav, it takes a little practice. Electron dense, you don't want it to be black. You want it to be somewhere between the two. So you can kind of see the dark cell in the middle, and then exactly those other ones are deposits. And you get used to that.
Okay. All right, so another EM here, blood space, urinary space. Again, no subepithelial or endothelial deposit. Food processes look normal here. Again, I would say this is like the darkish, so this would be like some deposits right here. Let's see if I see mesangial deposits. I know there's some here. Is this the
Yeah, there it is. Yeah.
And David, I'm sure this is just artifact, but I don't remember seeing this many like white holes in the, is that just artifact?
Yeah, that's just tissue tearing, I think is
Like-
what it is. Yeah.
Swiss cheese.
Yeah. And yeah, the GBM measured within normal limits, was not thin.
So, Chintav, what's your diagnosis?
IgA nephropathy.
Good. And I just want to bring up something from the chat. David brought up that light chains weren't always equal in IgA nephropathy. Neither Bill or I knew anything about that, but apparently it is a kind of a thing. But Dr. Rajasekaran, I hope I did that justice, basically wrote in the chat, we don't fully understand this lambda predilection in IgA nephropathy, but based on Dr. Nasser's 2001 KI paper using heavy light chain stainings, kappa is equal to lambda. So that may or may not be true. David, what do you see that, or is that something you're more used to reading in the past?
Actually, I have HEP installs from my predecessor, Dr. Schwartz, and it was
Mhm.
even documented back there, going back to the 2000s.
Yeah, well,
That
that may be obsolete information, but I'm not one to argue with Heptanstall. That's for sure.
yeah.
Nor should any of us, for that matter, until the new one comes out.
Now, Roger, the Lambda story has been flying around for a while, and I actually remember asking Dick Lassock about it over a year ago. He sent me a paper about it, and I think it was in the Journal of Immunology. And frankly, I didn't quite understand it. Dick, I don't know if you want to comment on that.
I can't remember the paper either, so I can't comment on it. Sorry.
All right. Well, when I find it, I'll share it with the group.
Yeah, so in Heptanstalls, it says that 65% of biopsies showed predominant staining for lambda by immunofluorescence.
Right.
Yeah, so typically the lambda is just a little brighter than the kappa. They're both there, but lambda is typically 2 or 3 plus, and kappa 1 or 2 plus.
Well,
It's
if it
not there in
exists,
every case, but I would say yeah. So they document here 65%. I would say it's about there from my experience.
well, regardless, it's something I hadn't heard of, so it's
There I just did a quick search. There's an article in a urology journal from the 90s, 96, that talks about how IgA plus lambda is more anionic and kappa is more cationic. So there's a relative charge difference, and that determines mesangial trapping. But I can't find a PDF to share it right now, but I could do that later.
Well, that is true. IgA is anionic and IgG is cationic in serum, which is a little bit of trivia here. Why elevations in IgA do not lower the anion gap, as do elevations in IgG and IgM. But I guess we're talking about light chains here, and I don't know, the kappa and the lambda, and I don't know, how that plays a role too. But it is interesting. It may play a role in why it deposits in the mesangium. I hadn't really thought about that. So we have a case of IgA nephropathy. David, we have a MES score on this.
David, you're muted.
I'm sorry, what was that question?
We have a MES score. It's got to be
Yes.
like 1, right? Because the mesangium is the only thing there.
Yeah, the mesangium was hypercellular. There was no endocapillary proliferation, no segmental scars. The fibrosis was minimal, no crescents. So yeah, just the M.
Cool. So Mario, tell me, what would you do with this? What would you do with this patient?
I'm sorry, I was looking for the paper. I'll probably manage her conservatively. I would probably put her on an ACE or an ARB and just follow her along. I see on the chat that somebody suggests Sglt2 inhibitors, and I still think those drugs are outrageously expensive and not everybody can afford it. I think as the price changes and more data comes out, aside from the data that we know was indirectly derived from Credence trial and others, I think would be appropriate. In regards to steroids, we are all aware of the recent report, I think, from the TREAT study in the latest ASN Renal Week, showing that reduced steroids have a favorable prognosis. But steroids are steroids. I think in a young lady like this one, with relatively normal serum creatinine, low-grade proteinuria, would just use an ACE or an ARB and follow her along.
Yeah, so I'm going to go into some of these studies a little bit in my discussion part. The SGLT, it's kind of all the rage lately. It isn't that easy to get. It's also maybe not as benign as we think, but it may be a big deal for some patients. The thing is, it's still pretty new, and wasn't even, I don't believe it was even mentioned in the new KDIGO, the guidelines, because it is, all that information is so new. And I don't think anybody would want to start that till they give a more, a trial of RAS inhibition first, but it may be a big part of our armamentarium in the future for patients that aren't responding, and as is steroids, and I'll get into that. Would anybody do anything differently? Would anybody give her steroids now?
I just, yeah, they all these add-on therapies like Plaquenil to lower proteinuria and even SGLT2, they just haven't been studied in the absence of using an ACE and ARB first. And so you could, they certainly will probably, or they will likely work, but I don't think that we can really, if we're going to play the evidence-based medicine game, use those as first line. I mean, it could be fun to consider, what is it, budesonide, the oral steroid one that's supposed to have that local effect that was recently approved. So I wouldn't do that here. I would look at what the proteinuria comes to after we use an ACE or an ARB, but it's kind of fun to think about.
Yeah, I hadn't really thought about that. So let's move to my slides.
I'll give you control here, Roger. Give me a second. Go ahead, click. Yep, that's you.
Okay, well, just very quickly, I started reading about IgA, and I was trying to prepare a whole discussion of IgA. It is a very complicated molecule. It exists as monomers, dimers, trimers, polymers. There's a secretory form. It's a lot more than I could do, and probably more than I would want to do for this talk. But basically, kind of the going theory of IgA nephropathy is that mucosal flora ends up leading to the production of IgA, but yet this IgA in some people genetically is galactose deficient, and that serves as an antigen, and so that you form IgG, anti-IgA galactose deficient antibodies. Then they can combine with the abnormal, inadequately galactosed IgA, it becomes circulating immune complexes, and then magically deposit in the mesangium and then lead to mesangial IgA disease. And this is a little simplification, but it is important to realize that, this is a very common problem. And, anytime I see something that's so common, you have to wonder why so many people are prone to have this galactose deficient IgA. When we think about most things that survive evolutionarily, they survive for an evolutionary advantage. Therefore, sickle cell trait is protective against malaria, and APOL1 high-risk genotypes are protective against sleeping sickness. And I wonder if there's something about this that makes this galactose deficient IgA protect us against something, because it's very, very prominent. And it's also very ethnically related, as we all know. So, I looked for it, I couldn't find a single thing, but I wouldn't be surprised if someday we find out that it has some advantage over some. And these things are always typically infectious diseases, because that's what we evolved for, was dying of infectious diseases, not the things that we die of today. But this is oversimplification, but it's kind of important. And so these circulating immune complexes then end up in the mesangium, and it may have to do with charge, as kind of was implied by Dr. Gashti. The amazing thing to me is that, it's a mesangial disease. So how does that mesangial disease then lead to red cells crossing this basement membrane, which typically you can occasionally see deposits in the glomerular basement membrane, but typically not. So how does that lead to red cell casts and destruction and crescents and segmental necrosis? I have no idea. So I think we still have a lot to learn about how, what the exact immune mechanism that leads to what's otherwise a mild mesangial disease can lead to, so many other severe things. I mean, it has really a different course than mesangial lupus, which if you just have mesangial lupus with low-grade proteinuria, you do pretty well. But this is also a mesangial disease, and maybe it's something about IgA. It's probably complement. Now we know complement associated with everything. We don't think, it's not a hypocomplementemic disease, but that doesn't mean much. So I went back and looked at the most recent KDIGO on GN, and chapter 2 is on IgA, covers both IgA with and without vasculitis. And of course, they have a nice reference to the prediction tool, which, quite frankly, I hadn't really used, but there is a link to it. And so you just click it on and it asks you 5 or 6 questions, or 13 questions actually. And it gives you the risk. You can ask it, how many months, how many years out do I want to know? 1 year out, 5 years out, and what the prognosis would be. So I did this with her. I mean, you could probably expect it to be a pretty good prognosis considering her pathology and her renal disease. But remember, when we first, here's this is the MES score. We kind of went over that already, but it's included in the tool. But when we first saw her creatinine was actually 0.8, and she's she's a tiny woman. And when I looked at her EGFR, it was quite greater than 90. I don't know what that means, but I know that when we repeated her creatinine, it was 0.6. That's a much, assuming those are real numbers, it's a much higher GFR. So I ran it with 2 different things. I ran it with her original presentation, which was a creatinine of 0.8, giving it a 90 and 1.1 grams of proteinuria. Now, and it gave me a 50%, the risk of a 50% decline in estimated GFR at 5 years was 12%. Still it's not bad. She's a pretty good prognosis after 5 years, but she's also a very young woman. But I kind of wondered because, after she had the vaccine, I thought, well, this has got to shoot up, right? If anything's going to happen, it's going to shoot up. She's had gross hematuria. And oddly enough, the day later when we did the biopsy, or 2 days later we did the biopsy, her proteinuria was only 500 milligrams. And, that's probably maybe some of the variation of protein creatinine ratios. But regardless, it was less. And now the creatinine was 0.6. And I arbitrarily gave her a EGFR of 120. Now she's down to 5.42%. And it just tells you have to take these tools with a grain of salt, and little differences here can make a big difference. I think what's really important was her MES score is not going to change either way. And I think she has a good prognosis regardless. And this is also very important to realize, whether it's 500 or 1,000, this is before therapy. We haven't even touched her yet with anything. So in the KDIGO guidelines, they still basically say, I'm going to skip most of what's in there. It's a nice document, but that they recommend anybody with proteinuria greater than 0.5 grams per day should be treated with an ACE or an ARB. And of course, that's going to be the case. And kind of based on the biggest prognostic cutoff of being about 1 gram a day. What was interesting here is that, they also finally put their, made their final decision on a few other things. So fish oil is now not recommended. So, I've never been a fan of it. So of course that made me happy. Mycophenolate, the data is really only in Chinese patients. And same thing with, Plaquenil, that it's really only been shown in Chinese patients. That doesn't mean it's not helpful, but these are, fish oil and Plaquenil, a lot of people have been using. It's kind of like, well, what's the harm, but the jury's still out on those. And I thought, and tonsillectomy, the same thing, that's commonly done in Japan and almost never done anywhere else. So it's hard to say, but in Japan, there's some evidence that tonsillectomy might play a role. I certainly would think if somebody had very large tonsils, it wouldn't be a crazy thing to take them out. I don't think it would be a routine thing though, but I don't know that we'll ever know that. What a slide I did leave out was what the KDIGO guidelines says. Anybody with persistent proteinuria greater than 1 gram should probably get a trial of steroids of 6 months of steroids. And so I want to give the background of some of this of the steroid story. And there's of course a lot, but the Stop IgA trial was the first big one to come out. Very well, fairly well designed and a large study, but basically was not a positive trial. And then this was I don't know, 6, 7, 8 years ago. And then just about a year ago, it came out that they looked at the 10-year follow-up, and there still was no a long-term follow-up or long-term benefit of giving the steroids in that. So, after that, steroids didn't do that well. They weren't really considered that strong of a therapy. So where did this all come from with the KDIGO guidelines? Well, it's probably was related to the testing trial, which I think Mario brought up. And of course, we have Dr. Glassick in the audience who knows the study quite well. And basically, it was, again, a trial to look at steroid for IgA nephropathy with a very select group of high risk prognosis based on proteinuria and EGFR. There was a high dose, which was 0.8 0.6 to 0.8 milligrams per kilogram per day of methylprednisolone, or a low dose, which is 0.4 milligrams per kilogram a day of methylprednisolone. And the high dose study got stopped early because of side effects. And so they continued the low dose cohort, and they added, I think, some more patients to it. With the primary endpoint being a 40% decrease in EGFR. And that was just, I don't think it's been published yet. And after I am done with this, I'll ask Dick for some comments, but I don't think it's been published yet. But I took a bunch of screenshots when it was being presented at the ASN last year. And so here it was 503 patients randomized to either placebo. They all had, I believe most had RAS inhibition, if not all. And there was, of course, a trial period of RAS inhibition before they would qualify. And they were either received methylprednisolone or placebo. And it was, not a lot of people discontinued. So it was well designed and had a very good follow-up and a very good, 86% completed the randomized treatment. That's always very good for a trial. And 98 completed, 90, they had a follow-up data on. So here's the baseline characteristics, because the problem with IgA nephropathy is you're not going to learn anything if you put somebody like my patient in the trial, because the risk of progression is very low. So you need someone who's going to progress to therefore show that they're not going to progress from what you do. And so these are the baseline characteristics. Various ethnicities, pretty well balanced by gender. Blood pressure is not high, but that's to be expected because it's important you control blood pressure before you consider anything else. But more importantly is, what was their renal situation? The mean proteinuria was 2.4 grams. I think they had greater than a gram to get in. And their EGFR is, hardly normal, not severely decreased either, because that's the other problem with the trial is you don't want to study IgA nephropathy with GFRs of 20 or 30 because it might be the point of no return. So I think this is really well designed. A little bit of renal insufficiency, not too much, fair amount of proteinuria that's not going down on standard therapy. And here you can see there, what they had, a significant, some of them had endocapillary proliferation. There was some fibrosis. These are not normal people. These are people that are progressing and therefore likely will progress if left alone. And that's what you want to study. And so here's the results of that. This is the composite of 40% decrease in GFR. And you can see a fairly nice risk reduction after 4.2 years. It was pretty sustained throughout there. And you can see, when you get towards 7 years, you don't have that many people, but you still got a decent, even at 4 years, you still have a large number of people being followed. And they had secondary outcomes. So the primary was 40%, but if you get 30% or 50% kidney failure, no matter how you look at it, had a very, very robust p-value. Death due to kidney failure, not really expected at this level. So that was nothing there. And very few people died, or death due to any cause, the same thing. So it's no surprise. And that was not really expected anyway. So, I mean, all in all, I think it was a fairly, fairly good trial and brought steroids back on the map. And it didn't matter whether it was the full dose or the reduced dose. They still saw a very nice risk reduction in the primary outcome with even the lower dose, which is very encouraging, not only because there's less side effects, but that's a lot less prednisone than before. And whether it's in China or not, everyone always asks. China seems to be the gold standard here, but you can see that the effect was, no matter where, was not country dependent. The only real issue is serious side effects. And here, this was when you look at everybody, there was a very significant decrease, increased risk in side effects on methylprednisolone relative to placebo. But the majority of these were in the full dose regimen and not really in the reduced dose regimen. This was, significant. It was 7 versus 3, but not really statistically significant. So and that may be not powered for that either. So, I believe there probably were more side effects, but nothing certainly like with the high dose. And I mean, it'd be hard to believe you wouldn't have some side effects with even the quote low dose prednisone. It's not minimal prednisone, it's just not as high. And this is, I think, a very impressive statistic that the number needed to treat over 2.5 years really isn't that high, for a trial. 7.3 for benefit and 13 for harm. You know, a lot of trials, you'll have a much, much greater number per 100 you have to treat before you start seeing an effect. So it's pretty good. Concluding that there was a decrease, major kidney outcomes by 40%, kidney failure by 41%. It was similar across pre-specified groups, and the incidence of serious events has increased, but mainly with a full dose therapy. And I think that's a fair conclusion about the side effects. So what is the background for budesonide? This was a paper done in Lancet in 2019. This is really the main study that's been released so far that supports this data. And you know, it has received FDA approval, but you know, it took several years. But this was a trial with patients, female or male, greater than 18 years. They had to have biopsy-proven IgA nephropathy, stable dose of RAS inhibition. They made a very strong point in that every patient in this trial was already on maximum tolerated dose before they put them in, with a urine protein creatinine ratio greater than 1 and an eGFR greater than 35 and less than 90. And then of course willing and able to give informed consent. And so they gave these patients either 16 milligrams of the drug, 8 milligrams. This is a steroid that's taken orally, and it does not get systemic. I don't know the exact pharmacology of how they do that, but it does not go systemically. It just basically, it heads towards those Peyer's patches and theoretically decreases the production of the inflammation that leads to the production of autoantibodies. So 16, 8, and placebo. And here you can see that this is the change in urine protein creatinine ratio from baseline. Here's our placebo group on top, and you can see what appears to be a dose different response to 8, 16, and 8 milligrams, with the best decrease in proteinuria is about 30%. So that may not seem like a lot, but we'll talk about that. This is over a year, and you can see over the year it's continuing to go down. And here is a change in eGFR from baseline. You can see that the placebo group did lose, 4 or 5 mLs per minute over that course of 1 year, whereas the 16 milligrams did 8 milligrams less. So, this was really designed as a proteinuria trial, but they weren't, and it is 12 months, but definitely was rather impressive from that standpoint, at least from the proteinuria standpoint. There really wasn't any difference in side effects, unlike systemic steroids in the testing trial, which is, of course, their big sell here, is that it's a local treatment that has a pretty good effect. And I want to make a point that this is in their discussion. They said proteinuria reduction was significantly associated with outcomes in end-stage renal disease and other meta-analyses. For each 30% reduction in proteinuria, remember, that's about what we saw here, 30% reduction in proteinuria. By drugs that intervene with the RAS, the risk of end-stage renal disease decreased by 30%. So it's kind of equivalent. So I don't know if you can say that's going to be the case here, but we know that proteinuria is a predictor of poor outcome, and lowering proteinuria, it's a modifiable risk factor. So it's very likely to believe that 30% in proteinuria will translate into something clinically. Just last year in medicine, this was a report of the same drug being used versus systemic steroids, very small group, 18 patients in each. This was retrospective. So they had 18 patients that they gave budesonide to, and they matched them with 18 patients that also had IgA nephropathy that got systemic steroids, and they propensity matched for age, renal function, proteinuria, hematuria, and MES score. So hardly randomized, but trying to give them a control group. And you can see here that their MES scores, the 24-year proteinuria was 1.3, 1.4 grams, and their creatinine was elevated. So these are patients that should be high risk and should progress if nothing is done. And what they found was that every other hero one, I don't know what color these are because I'm colorblind, but the budesonide ones, you can see generally this is change in proteinuria, are always lower than the ones that received steroids. And same thing is true when you look at the change in the hematuria, which is kind of interesting because that would imply less inflammation, and hematuria isn't typically thought of as a risk factor, but we do know that patients that have consistent microscopic hematuria have a worse outcome than those that have just intermittent gross hematuria. So, I mean, I think this is a good indicator that the inflammation is going down. It'd be fun to actually do a biopsy study with some of these things and see if that shows up. And then finally, I just found this, but apparently the Nefecon, which is the trade name for this drug, just released their phase 3 results. This was back in Montreal in 2021 at the ISN. And they now found at 9 months, the urine protein creatinine ratio again by about 30% compared with placebo group. And at 9 months, a statistically significant change in the EGFR compared with placebo. And I don't know if this was available when the FDA looked at it or not, or if they only look at abstracts or whatever. But what is interesting is it was approved just last year, but it's approved to decrease proteinuria. It's not a drug these are things that are really important to the FDA, how they label something. But, we know that proteinuria is a big deal for renal disease. So, maybe as more data comes out, it will also be approved for GFR as well. And so that's kind of where we're at. And we're kind of waiting to see when it becomes available in the US market. And what the cost will be, nothing is cheap anymore. And hopefully it's not, it'll be cheaper than SGLT2 inhibitors or basically, everything else that hits the market these days. So what I would, I agree with everybody. We put her on a little bit of an ARB, and we'll, in a couple months, we'll check her proteinuria and kind of go from there. I don't think there's any rush to do anything. If it doesn't go down, I'll increase the dose. If it doesn't go down, I might add an SGLT, or I might add a ARB to it. There's a lot of options out there. I'm not a fish oil person. I have used Plaquenil. We'll just have to see how she does. But right now, I think she's got a good prognosis, and I don't think she needs much anything else. Dick, what are your, why do you think the testing trial was positive compared to Stop IgA?
Well, in my opinion, it was due to the fact that the patients enrolled in the testing trials had more severe disease. The proteinuria at baseline was roughly double that seen in the Stop IgM trial. The GFR was, as you've just shown, 60 versus 80. So I think the differences in the two trials are mainly due to the severity of the disease at entry. Mm-hmm. Unfortunately, we don't know what the full MES score was for the testing trials. That's not been reported. We do know the MES scores in the IgA, Stop IgA trial, and except for crescents, there really was no evidence that the MES score had any important effect on the outcome of the trial.
I had a slide. I didn't somehow missed it or skipped it or whatever, but it basically had the decrease in GFR compared in the testing trial and the ezetimibe trial, and it's pretty similar actually. So it's kind of an exciting, when you compare placebo, what the placebo group did, they lost 5 or 6 mLs a minute. Oh yeah, thank you. So here is the Nefecon. The placebo group lost about 6 mLs a minute, whereas the high dose really didn't lose any. And if you go over to the testing trial here, this was back when it was still the high dose, but and the low dose had at least as good or better renal protection. But again, about the placebo group lost about 7 mLs a minute, and the treated group about maybe 1 ml a minute. So it seems to have, at least in this, similar effect, and it would be great if this drug works and is tolerable and affordable, because I mean, hopefully it is testing the testing trial without the side effects of steroids. But Dick, are you convinced enough from the data out there? I mean, the FDA is a pretty tough to convince the FDA. Do you feel comfortable? Would you try it?
Well, I think it's certainly, as an approved drug, it's worth a trial. However, you have pointed out, and I'll emphasize, the FDA did not approve the drug for renal protective effects, only for reduction in proteinuria. They were not convinced that the data available at the time of approval was sufficient to approve this drug for prevention of progressive loss of GFR. We'll have to wait to see the follow-up on these patients to make a determination as to its renal protective effects.
What's the status of the testing a manuscript? Is it is it about to come out?
It's under review.
Okay. And it'll be, I'm sure the same thing's true of the ezetimibe trial at the ISN. So I think, there's, IgA we have advanced, for years we were in limbo with IgA, fighting about fish oil and everything else, but I think we're getting somewhere, and it's all about trial design, because if you don't study the right patients, you're not going to get the right answer, and I think that's the message here. We've run over a little bit. I'm going to wrap this up. Thank you, everybody. That video that didn't work, I'm really sorry about that, because it's really pretty slick. We will send out to the mailing list. I'll send you out the link to that. So if you at all want to see it, we will probably be back next week. Check your email. In the meantime, everybody stay safe, and thanks for coming.